Welcome to the Hospital Medicine Unplugged podcast.
Thank you for having me. This is an incredibly important topic to cover today.
Absolutely. Today we are doing a comprehensive physician-to-physician deep dive into the modern clinical management of ANCA-associated vasculitis. And, we really have to stress from the outset that the entire paradigm for managing these devastating diseases is undergoing a massive fundamental shift right now.
Right. For decades, your approach as a clinician relied heavily on blunt, highly toxic immunosuppression. We essentially accepted severe acrogenic damage as the unavoidable cost of keeping our patients alive.
Which is a terrible trade-off. But now we're moving decisively toward highly targeted, steroid-sparing therapies and serotype-driven clinical decision-making. So to guide this deep dive, we are synthesizing the most critical, up-to-date sources. This includes the comprehensive 2021 American College of Rheumatology and Vasculitis Foundation guidelines.
And we are also heavily utilizing the newly released 2024 KDIGO guidelines for the management of glomerular diseases.
Exactly. We're also going to dissect the pivotal trial data that you absolutely must know if you are a practicing hospitalist, intensivist, or nephrologist. We will analyze the Advocate, Paxivus, Manritson, and Mandara trials alongside emerging targeted biologic therapies. Because when you are seeing these patients, whether in your clinic or managing acute organ failure on the wards, a superficial understanding just doesn't cut it anymore. Mastering this new paradigm is the absolute standard of care.
It really is the clinical reality you face today. The margin for error in managing severe systemic vasculitis is incredibly narrow. Relying on outdated legacy protocols will actively harm the patients under your care.
So, to understand where we are going with these modern therapies, you first have to understand the epidemiological landscape, right?
Right.
Because the demographic profile of the patients you are admitting today looks remarkably different than it did 20 or 30 years ago.
It does. If we step back and look at the global pooled incidence, it sits at approximately 17.2 per million person years, with a pooled prevalence of 198 per million persons.
But when you look at the specific data for the United States, it is a bit different. The annual incidence is roughly 3.3 per 100,000 population, with a significantly higher prevalence of 42.1 per 100,000.
And you really have to break that incidence down by clinical subtype to make it useful. Granulomatosis with polyangiitis, traditionally known as GPA, has an incidence ranging from 9.0 to 15.6 per million. Microscopic polyangiitis, or MPA, ranges from 5.9 to 6.5 per million.
And then there's the rarest one, right? Eosinophilic granulomatosis with polyangiitis, or EGPA. That presents with an incidence of just 1.7 to 2.7 per million person years.
Right. But the really striking part is the evolution of these numbers over time. Incidence and prevalence have definitively increased over the past 30 years.
Which begs the question for the clinician looking at this data, are we witnessing a true biological explosion of systemic vasculitis?
Well, no. When you critically analyze the variables, it is clear the biological incidence is relatively stable. The increase is driven by improved clinical recognition. Primary care physicians and hospitalists are simply better at spotting it. Plus, we have evolving classification criteria and, crucially, the widespread availability of highly sensitive ANCA testing.
Right, so we were just finding the disease that was always there, hiding as generic interstitial lung disease or idiopathic chronic kidney disease.
Exactly. Furthermore, the demographic target is actively shifting. The peak age at onset has moved toward older populations over the last 20 to 30 years. The mean age at diagnosis is now sitting right at 61 years.
Which is profound when you think about the clinical implications. You are now diagnosing a heavy immunosuppression disease in an older cohort. A 61-year-old patient almost certainly brings compounding comorbidities. They have essential hypertension, type 2 diabetes, or underlying chronic kidney disease.
And the clinical gravity of that cannot be overstated. When you initiate traditional high-dose cyclophosphamide and prolonged high-dose glucocorticoids in a diabetic patient in their 60s, you are initiating a race between disease control and iatrogenic mortality.
It is terrifying. The risk of overwhelming infections, metabolic derangements, accelerated cardiovascular disease, that is exactly why the shift towards steroid-sparing therapies is so incredibly urgent. You are actively managing the survival of an aging immune system.
And adding another layer to this is the geographic variation. You will find that GPA is notably more common in northern latitudes, like Northern Europe and the northern United States.
Well, MPA dominates the clinical landscape in Southern Europe, Asia, and the Pacific.
Right, and this distinct geographic phenotype has massive implications. It affects how you interpret global clinical trials, and it absolutely should inform your differential diagnosis depending on where you practice or where your patient migrated from.
I want to stop you right there and unpack that underlying pathophysiology. Because historically, throughout our medical training, we were taught that ANCA-associated vasculitis was an autoimmune disease driven almost entirely by B-cell autoantibodies directly activating prime neutrophils. The complement cascade was just an afterthought.
It was treated as a secondary bystander, yes, but the shift in understanding the alternative complement pathway is perhaps the most critical pathophysiological breakthrough in this field over the last 2 decades.
So when exactly did it move from being a bystander to the primary engine of the disease?
Well, the initial binding of the ANCA to the target antigens, proteinase 3 and myeloperoxidase, is still the instigating event. But exhaustive research has proven that the alternative complement pathway drives the catastrophic tissue destruction. When ANCA binds the neutrophil, it initiates a localized activation of the alternative complement pathway.
And that cleaves complement component C5, generating C5a.
Exactly. And C5a is an exceptionally potent anaphylatoxin. Its interaction with the C5 receptor 1 on nearby neutrophils triggers a vicious amplification loop.
To make this actionable for the listener trying to visualize this at the cellular level, C5a is acting in a dual capacity here. It acts as both a powerful neutrophil chemoattractant, drawing massive numbers of inflammatory cells into the fragile endothelium of the glomerulus, and as a direct activator.
Right. It causes the neutrophils to violently degranulate. They release highly destructive reactive oxygen species and extrude neutrophil extracellular traps.
Which releases even more antigens into the microenvironment, binding more ANCA, activating more complement, and generating more C5a. It is just a terrifyingly efficient cycle.
It is. And for the physician evaluating a patient, this has direct, measurable clinical correlations. When you admit a patient with rapidly progressive glomerulonephritis, you order complement panels. If you observe low circulating C3 levels in the serum, you must recognize this as a severe biomarker of aggressive disease.
Because the low C3 correlates independently with a worse renal prognosis and higher rates of resistance to standard therapy.
Yes, and this systemic finding is mirrored at the microscopic tissue level. When the renal pathologist reviews the kidney biopsy, they frequently note distinct deposits of C3d and properdin on the immunofluorescent staining.
And properdin is a positive regulator of the alternative pathway, right?
Right.
So its presence provides absolute proof of local alternative pathway activation happening right at the site of glomerular injury.
Exactly. The density of those deposits correlates directly with the percentage of cellular glomerular crescents and the severity of proteinuria. It is this exact understanding of the C5a-driven amplification loop that provided the rationale for developing avacopan,
which we will absolutely dive into shortly.
Right.
But this molecular understanding parallels a major shift in how we classify these patients. The current standard demands that you classify your patients by both their clinical phenotype GPA, MPA, or EGPA, and their ANCA serotype, meaning PR3 ANCA versus MPO ANCA.
Relying solely on the clinical syndrome is no longer adequate for guiding therapy or predicting prognosis. You have to integrate both dimensions.
Let's do a deep comparative analysis of PR3 versus MPO. We mentioned the geography, PR3 in the north, MPO in the south, and Asia. But the organ involvement is starkly different.
Very different. PR3 ANCA disease tends to be a widely distributed, multi-organ, aggressively necrotizing disease. These patients classically present with severe involvement of the ear, nose, and throat destructive sinusitis, saddle nose deformities, subglottic stenosis.
And in the lungs, PR3 is uniquely associated with the formation of large, thick-walled cavitary pulmonary nodules.
Contrast that with MPO-ANCA disease, which frequently presents with much more focused pathology. It often presents as a severe renal-limited microscopic polyangiitis.
Or uniquely to the MPO serotype, it is strongly associated with chronic, progressive, fibrosing interstitial lung disease.
Right. And this distinction becomes paramount when you discuss long-term relapse versus mortality risk with the patient. As you follow these cohorts, there is a fascinating inverse relationship. Patients with PR3 ANCA carry a substantially higher risk of subsequent disease relapse.
Their immune systems are just highly prone to reactivation.
But despite that high relapse frequency, PR3 patients have a similar or even slightly lower overall long-term mortality rate. MPO-ANCA disease has a lower rate of acute relapse, but carries a demonstrably higher overall mortality rate.
Which is largely driven by that progressive pulmonary fibrosis we just mentioned. Unlike the acute inflammatory lesions of PR3, the usual interstitial pneumonia pattern with MPO is mostly fibrotic. It inexorably progresses to severe hypoxemia and right heart failure.
And that precise serotype classification directly informs your therapeutic expectations. Evidence indicates PR3 patients have a preference for rituximab over cyclophosphamide for initial induction, but rituximab and cyclophosphamide appear equally effective for achieving initial remission in MPO patients.
I want to pivot and unpack EGPA, because the conceptual paradigm shifts entirely here. You must practically divide EGPA into two distinct clinical pathologic subsets based on ANCA status.
This is a major trap in practice. Only 30 to 40% of EGPA patients are actually ANCA positive. This minority is driven by true vasculitic manifestations, necrotizing glomerulonephritis, palpable purpura, sudden onset mononeuritis multiplex.
Like a devastating foot drop from ischemia to the vasa nerve.
Exactly, but you must contrast that with the remaining 60 to 70% who are entirely ANCA negative. Their disease is driven almost entirely by massive tissue infiltration by eosinophils.
So they present with severe lung infiltrates, gastrointestinal involvement, and profoundly dangerous eosinophilic cardiomyopathy.
You must continuously emphasize to your teams that a negative ANCA test cannot give you a false sense of security. If you rule out EGPA just because the immunoassay is negative, you will actively miss the vast majority of these diagnoses until irreversible organ damage occurs.
Because only 40% produce detectable ANCA. And severe late-onset asthma is a defining feature present in nearly 100% of these patients. You also have to maintain a high index of suspicion for cardiac involvement, which is a major cause of sudden mortality here.
Moving to the clinical manifestations at the bedside, organ-specific prevalence data helps you prioritize your diagnostic workup. Renal involvement occurs in roughly 70 to 80% of GPA and MPA patients. The absolute hallmark is poikimmune necrotizing crescentic glomerulonephritis.
And we should clarify what poikimmune actually means for the clinician forming a differential. It refers to the relative lack of dense immunoglobulin or complement deposition on immunofluorescence.
Right. This distinguishes it from the intense full-house staining seen in severe lupus nephritis, or the smooth linear deposition that is pathognomonic for antiglomerular basement membrane disease.
Also, MPO-NCA presents with a broader range of renal manifestations than PR3. PR3 patients almost universally present with acute crescentic changes, while MPO patients frequently present indolently, sometimes with advanced fibrotic lesions already established at the time of diagnosis.
Beyond the kidneys, mapping pulmonary findings to serotypes is critical. Cavitary nodules are almost entirely exclusive to PR3. The usual interstitial pneumonia pattern almost always occurs strictly with MPO.
But diffuse alveolar hemorrhage is the terrifying equalizer. It is an equal opportunity complication for both serotypes, presenting with massive hemoptysis and sudden respiratory failure.
To identify these serotypes, you have to use modern diagnostic evaluation standards. There has been a definitive shift away from the legacy method of indirect immunofluorescence testing. Guidelines now unequivocally recommend highly specific immunoassays for detecting PR3 and MPO antibodies as the primary screening method.
The test metrics are excellent, 90 to 95% sensitivity for active GPA or MPA, and greater than 95% specificity.
However, you must keep the diagnostic gap in mind. Approximately 5 to 10% of patients with true severe GPA or MPA and 60 to 70% of EGPA patients will be entirely ANCA negative on modern immunoassays. You cannot let a negative serology override objective clinical deterioration and definitive histological evidence.
The serology supports the diagnosis, it does not dictate it. So once you have the diagnosis, you are on the clock. You must initiate induction therapy rapidly to halt organ necrosis. The 2021 ACR and Vasculitis Foundation guidelines, supported by the 2024 KDIGO guidelines, establish a grade 1B recommendation. Systemic glucocorticoids combined with either rituximab or cyclophosphamide.
But the paradigm heavily prefers rituximab for the vast majority of patients. This preference is absolute for relapsing disease and for those with the PR3 ANCA serotype, given their inherently higher biological risk of relapse.
So cyclophosphamide is no longer the default. You have to identify its specific niche.
Yes. You should reserve aggressive cyclophosphamide primarily for patients presenting with severe, acute, life-threatening kidney failure. Specifically, patients with an estimated glomerular filtration rate of less than 15 milliliters per minute, or those entirely dependent on acute hemodialysis at presentation.
Because in those rapidly deteriorating scenarios, the rapid onset of alkylating cytotoxicity might halt ongoing glomerular necrosis faster than rituximab, which requires time to achieve B-cell depletion.
Exactly. It is a calculated risk, weighing the immediate threat of permanent end-stage renal disease against the severe risks of gonadal toxicity, intense bone marrow suppression, and future malignancy.
When you do select rituximab, you have two equally effective dosing protocols. The FDA-approved regimen is 375 milligrams per square meter administered weekly for 4 doses. Or you can use the fixed-dose regimen of 1,000 milligrams administered for 2 doses spaced 2 weeks apart, which is highly supported by retrospective studies.
The fixed-dose regimen often simplifies outpatient infusion center logistics. But perhaps the most revolutionary change in modern induction therapy involves the glucocorticoid component.
Right. For decades, we subjected patients to massive, agonizing courses of high-dose steroids, accepting severe iatrogenic toxicity, vascular necrosis, myopathy, opportunistic infections as the cost of survival.
But the Pathophysiology and Low-Vest trials completely dismantled that assumption. As a clinician, you must now utilize heavily reduced-dose glucocorticoid regimens. The Pathophysiology trial definitively proved that a rapid steroid taper, resulting in a much lower total cumulative dose, drastically reduced the incidence of serious infections at 1 year.
And crucially, it did this without any statistically significant increase in end-stage renal disease or overall mortality. We finally proved that less is more. The Low-Vest trial confirmed this, showing excellent remission rates when an accelerated taper was combined with rituximab.
But if we pull back on steroids, we theoretically leave a dangerous gap while waiting for rituximab to take effect. How do we rapidly protect the kidneys? That exact dilemma drove the development of avacopan, marketed as Tavneos.
Avacopan is an oral C5, a receptor 1 antagonist, FDA approved in 2021 as an adjunctive treatment for severe active disease. By blocking the C5 receptor on neutrophils, you abruptly halt that destructive complement-driven amplification loop we detailed earlier.
To understand how to utilize this, you must analyze the Advocate trial. They randomized patients to receive either a standard prednisone taper or avacopan, both on top of rituximab or cyclophosphamide induction.
And the data is practice-changing. Remission at week 26 was definitively non-inferior, 72.3% for avacopan versus 70.1% for prednisone. But the critical divergence occurred at week 52.
Right. Sustained remission at week 52 was statistically superior in the avacopan group, reaching 65.7% versus 54.9% with the standard prednisone regimen. That is a highly significant p-value of 0.007.
And there are profound objective implications for kidney function. Patients receiving avacopan demonstrated an increase in their EGFR by 7.3 milliliters per minute per 1.7, 3 squared meters at week 52. This is compared to a smaller recovery of only 4.1 milliliters per minute per 1.7, 3 squared meters in the prednisone group.
Furthermore, a post-hoc analysis showed even greater magnitude of GFR recovery in the most vulnerable subset, those starting with an EGFR of less than 20 milliliters per minute per 1.7, 3 squared meters. For patients hovering on the brink of dialysis, avacopan provided a massive advantage.
When applying this clinically, avacopan is dosed orally at 30 milligrams twice daily. The ideal candidate profile is clear. You should consider it for patients at dangerously high risk for glucocorticoid toxicity, brittle diabetics, severe osteoporosis, psychiatric comorbidities, and those with lower baseline GFR who critically need to maximize renal recovery.
However, you must be acutely aware of the populations excluded from the Advocate trial. They excluded patients with a life-threatening EGFR of less than 15 milliliters per minute and those with fulminant diffuse alveolar hemorrhage requiring mechanical ventilation. So if you are in the ICU facing those exact scenarios, avacopan is outside the primary trial evidence for acute rescue.
And its role as a long-term maintenance therapy requires further study. Current approval is strictly limited to adjunctive use during acute induction. Now, while avacopan is an undeniable leap forward, we have to talk about therapeutic plasma exchange, which has become incredibly controversial.
It is a sobering example of entrenched dogma yielding to rigorous modern data. For over a decade, we relied on the 2007 MIPEX trial, which showed improved kidney outcomes at 12 months for patients with severe renal disease, strictly defined as a serum creatinine greater than 5.7 milligrams per deciliter.
That trial culturally entrenched plasma exchange as the absolute standard of care. But you must starkly contrast that with the massive 2020 Paxlovid trial.
Paxlovid completely failed to demonstrate any statistically significant benefit for the composite endpoint of end-stage renal disease or death over a follow-up of 2.9 years. When you synthesize this through meta-analysis, the consensus is that plasma exchange probably reduces the absolute one-year risk of end-stage renal disease, but it significantly increases the risk of serious, potentially fatal, opportunistic infections.
So it is an incredibly nuanced risk-benefit ratio. This is perfectly reflected in the 2022 BMJ Rapid Recommendation Framework and the 2024 KDIGO guidelines. They've adopted a highly precise, risk-stratified approach.
If you determine a patient has a low or low-moderate risk of progressing to end-stage renal disease, the guidelines issue a weak recommendation against routine plasma exchange. The infectious risks undeniably outweigh the theoretical benefits.
Conversely, for patients you stratify as moderate high or high risk, there is a weak recommendation in favor of initiating it. To make this actionable, you need concrete clinical triggers. You should consider ordering plasma exchange if the admission serum creatinine is greater than 3.4 milligrams per deciliter, if they already require hemodialysis, or if the creatinine is aggressively increasing despite induction therapy.
And regardless of renal function, you absolutely initiate emergent plasma exchange for diffuse alveolar hemorrhage with life-threatening hypoxemia, or in the rare scenario of concurrent antiglomerular basement membrane disease, where rapid removal of autoantibodies is vital.
Once you navigate the induction phase and achieve remission, your focus must aggressively shift to maintenance therapy optimization. Your entire goal is to prevent organ-destroying relapses. Across the ACR, Vasculitis Foundation, ELOR, and KDO guidelines, rituximab is firmly established as the preferred first-line maintenance agent.
The profound clinical superiority of rituximab over traditional oral agents like azathioprine was proven in 2 pivotal trials. The main Ritson trial evaluated patients who achieved remission after cyclophosphamide induction. Rituximab completely crushed azathioprine, with a major relapse rate of only 5% compared to a staggering 29% in the azathioprine arm.
Then the rituximab trial evaluated an even higher risk cohort, patients with relapsing disease who had just undergone rituximab induction. Continuous rituximab maintenance again proved superior to azathioprine, restricting relapses to 15% versus 38%.
Having established rituximab as the agent of choice, the single most complex question you will face is determining the optimal duration of maintenance therapy. Current data suggests the optimal duration ranges widely from 18 months to 4 years post-induction, with EULAR strongly recommending at least 24 to 48 months.
You have to continuously analyze the biological trade-off. Extending rituximab duration unequivocally reduces vasculitic relapses, but comes at the cost of cumulatively increasing adverse events, specifically profound hypogammaglobulinemia and a highly elevated risk of severe respiratory infections.
Interestingly, legacy data on oral agents supports extended maintenance. Extending azathioprine from 2 years to 4 years significantly decreased both relapse and kidney failure. To safely personalize this decision, you use specific predictive factors.
You should strongly favor a prolonged multi-year maintenance course for patients who possess the high-risk PR3 ANCA serotype, those with a history of prior relapse, patients with critical irreversible baseline organ damage like cardiovascular or fibrosing lung involvement, and patients exhibiting persistent ANCA positivity despite clinical remission.
We must now pivot to the distinct management protocols for EGPA. As we discussed, this is a completely different therapeutic landscape, heavily focused on the precise inhibition of the interleukin-5 pathway.
The transition to precision medicine here started with mepolizumab, the first targeted biologic therapy approved for this indication. It is an anti-IL-5 monoclonal antibody dosed at 300 milligrams subcutaneously every 4 weeks. In trials, mepolizumab achieved a significantly longer duration of remission, higher overall remission rates, drastically lower relapse rates, and meaningfully reduced systemic glucocorticoid use compared to placebo.
Building on that success, benralizumab recently received FDA approval for EGPA in 2024. Benralizumab is a distinct anti-IL-5 receptor alpha monoclonal antibody, administered at a much lower mass dose of only 30 milligrams subcutaneously every 4 weeks.
To properly position these biologics, you have to analyze the highly anticipated MANDARA trial. This pitted benralizumab directly against mepolizumab to definitively establish statistical non-inferiority.
And successfully confirmed that non-inferiority. The remission rates at weeks 36 and 48 were 58% for benralizumab versus a very comparable 56% for mepolizumab. But as a clinician, you must delve into the distinct pharmacological mechanism of benralizumab to appreciate its profile.
Because benralizumab targets the IL-5 receptor alpha subunit directly on the eosinophil surface, and because it is structurally fucosylated, it leads to a much more rapid, near-total eosinophil depletion.
Yes, mepolizumab essentially works by starting the eosinophils. It binds free-circulating IL-5. Benralizumab acts as an assassin. It binds directly to the receptor and triggers direct eosinophil apoptosis through antibody-dependent cell-mediated cytotoxicity, actively recruiting the patient's natural killer cells.
This profound cellular depletion translated directly into a major clinical victory in the MANDARA trial. A significantly higher proportion of patients receiving benralizumab achieved complete 100% systemic glucocorticoid withdrawal. We are talking about 41% of benralizumab patients coming off steroids entirely, compared to 26% in the mepolizumab arm.
Furthermore, we now have the 2-year MANDARA extension data, which demonstrates exceptional long-term durability. At week 104 of continuous therapy, 62 to 68% of patients remain safely in sustained clinical remission, with 43 to 44% successfully maintaining that complete glucocorticoid withdrawal.
When applying this to your daily practice, you must be clear on the strict indications. These advanced biologics are specifically indicated for patients suffering from non-severe, relapsing, or highly refractory EGPA, or those requiring profound glucocorticoid-sparing intervention.
You must remember that if a patient presents with severe acute EGPA defined by life-threatening organ involvement like crescentic glomerulonephritis or sudden eosinophilic myocarditis, these targeted biologics are dangerously insufficient for acute rescue. Severe presentations still require immediate, massive induction therapy with cyclophosphamide or rituximab, combined with high-dose intravenous pulse glucocorticoids.
Only after the acute crisis is averted can you consider adding IL-5 inhibitors for long-term maintenance or to facilitate a steroid taper. Truly understanding these nuances allows us to accurately counsel patients on their long-term prognosis.
And the historical contrast in survival should continually remind you of how far we have advanced. Prior to modern immunosuppression, median survival for severe GPA was a devastatingly brief 5 months. It was uniformly fatal. Today, utilizing these highly targeted regimens, 5-year survival rates have improved to approximately 70 to 80%.
But you must contextualize this success by acknowledging the ongoing mortality gap. Despite our absolute best therapies, overall mortality remains significantly elevated when directly compared to the healthy general population. This is particularly pronounced for MPA and EGPA, driven heavily by chronic organ damage, cumulative toxicity of immunosuppression, and accelerated cardiovascular disease.
You must also vigilantly monitor for acute disease relapse. Relapse rates are stubbornly high, occurring in 30 to 50% of all patients within just 5 years of diagnosis.
As we established, relapse rates are predictably higher in PR3-ANCA disease compared to MPO-ANCA, and higher in the GPA phenotype compared to MPA. When formulating a long-term prognosis, you must summarize the established poor prognostic factors.
A patient faces a statistically worse long-term outcome if they have a significantly older age at diagnosis, if they present with severe peripheral nerve involvement like mononeuritis multiplex, if they inherently carry the MPO-ANCA serotype due to the high incidence of untreatable pulmonary fibrosis, and if they present with severe advanced renal involvement at baseline.
Before we conclude this comprehensive review, you must be fully educated on one final differential diagnosis: drug-induced ANCA-associated vasculitis. You will inevitably encounter patients presenting with exact features of this disease, but their condition is artificially triggered by specific pharmacological exposures.
As the admitting physician, you must rapidly review the medication list. Historically, hydralazine and propylthiouracil are the most common offenders. But you must also look for minocycline. Carefully inquire about exposure to levamisole, which is frequently an adulterant in illicit cocaine, and recognize that tumor necrosis factor inhibitors can paradoxically trigger this syndrome.
The clinical signature is highly distinct. These patients are almost exclusively heavily MPO-ANCA positive, often with atypical quantitative laboratory titers. Occasionally, you will observe the incredibly rare phenomenon of dual positivity, where they test highly positive for both PR3 and MPO-ANCA.
When you see dual positivity, it is almost definitively pathognomonic for a drug-induced etiology. Crucially, the severe disease process usually resolves completely with prompt discontinuation of the offending drug. However, you must be prepared to initiate short-term aggressive systemic immunosuppression if the patient presents with highly organ-threatening manifestations.
Looking beyond our current standard of care, the horizon of therapy is expanding incredibly rapidly through intense emerging research. Given the profound success of avacopan, there is massive investment in developing next-generation alternative complement pathway inhibitors.
We are also seeing rigorous evaluation of next-generation B-cell targeted therapies like obinutuzumab, a more potent type 2 monoclonal antibody that induces deeper tissue depletion than rituximab. Researchers are also exploring novel Bruton's tyrosine kinase inhibitors, or BTK inhibitors, and Janus kinase, or JA inhibitors.
Alongside novel drugs, there is an ongoing search for predictive biomarkers to precisely guide therapy. The clinical utility of tracking quantitative ANCA titers is heavily debated. While rising titers may theoretically predict relapse, the evidence remains inconsistent. You absolutely should not escalate highly toxic immunosuppression based solely on a rising titer in an asymptomatic patient.
Tracking the exact kinetics of peripheral B-cell reconstitution after rituximab provides some temporal data, but we are desperately awaiting validation of precise biomarkers that can unequivocally confirm subclinical disease activity before organ damage occurs.
Ultimately, all of this massive research is driving us, inevitably, toward an era of true personalized medicine. The 2022 ACR and EULAR classification criteria aim to vastly improve clinical standardization. This pushes the global field toward a future where your daily clinical decisions are strictly defined by precise ANCA serotype-guided therapy, risk-stratified maintenance durations, and biomarker-guided dosing.
The goal is to give the exact right amount of drug at the exact right time to the exact right patient, minimizing toxicity while absolutely maximizing survival.
To synthesize this highly extensive deep dive, the most critical takeaway for your clinical practice is acknowledging the massive paradigm shift we have discussed today. We are definitively moving away from an archaic era characterized by broad systemic toxicity and squarely into a modern era defined by precision targeting. Your management must now be meticulously guided by the patient's specific ANCA serotype, a sophisticated physiological understanding of the alternative complement pathway, and the application of steroid-sparing trial data.
Given the striking, undeniable success of targeted complement blockade with avacopan and the highly impressive rates of complete permanent glucocorticoid withdrawal seen with benralizumab in the Mandara trial, are we actively witnessing the final days of systemic glucocorticoids in the management of severe systemic vasculitis? Will the very next generation of our fellow physicians look back at our heavy reliance on high-dose steroids as a blunt, incredibly archaic medical instrument?